Most students lose marks in shoulder biomechanics not because it's difficult, but because they mix up the basics. In the next 10 minutes, I'll make your shoulder anatomy so clear that you won't need to revise it again before exams. This is part 1 of the 4-part series of shoulder biomechanics based on Norkin. If you understand this properly, the rest of the chapter becomes very easy, especially the kinetics, kinematics, and clinical reasonings. This is exactly how it is explained in Norkin's, but I'll simplify it for exam use and clinical understanding. By the end of the video, you will clearly understand all the shoulder joints, key ligaments linked to impingement, and how to remember muscles without confusion. And trust me, if you miss this one concept, your entire shoulder biomechanics will feel confusing. The shoulder complex helps in maintaining maximum mobility and stability via 4 functional and structural joints. These include the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and one functional joint which is not a true joint structurally but is a functional joint, the scapulothoracic joint. Now coming to sternoclavicular joint, the sternoclavicular joint serves as the singular axial anchor for the upper extremity because this joins the clavicle, that is the entire part of the upper extremity, with the appendicular skeleton, that is the sternum. Anatomy: it is a complex compound plane synovial saddle joint. Now here the surfaces of the clavicle and the manubrium sterni are very subtle, that is why it is classified as plane synovial saddle joint. Articular disc is fibrocartilaginous and it attaches diagonally from the posterior superior clavicle region to inferior manubrium sterni region, that is from posterior superior region of the clavicle to inferior manubrium sterni. The space of the joint of sternoclavicular joint is a wedge shape and is open superiorly. Remember this for your CET MCQ. Now the vascular and neural spaces. Blood supply is via internal thoracic and suprascapular arteries. The nerve supply via medial supraclavicular and nerve to subclavius. The concave-convex rule, we will be discussing arthrokinematics in the further upcoming lectures, but just a brief about it. So according to the concave-convex rule we learned in the last lecture video, for the sternoclavicular joint, elevation and depression, convex clavicle surface will ride over the concave sternum, that is roll and glide will happen in the opposite direction. Whereas for protraction and retraction, again the concave clavicle will ride on the convex sternum, that is the roll and glide will occur in the same direction. Now since the surface is saddle shaped, we have different surfaces of the clavicle moving over the sternum, and that is why the concave convex rule here is a bit confusing, but if you remember the articular surfaces well, it becomes very easy for you. Specific ligamentous restraints strictly dictate the 6 degrees of sternoclavicular freedom. Every joint has capsule, ligaments, and the intra-articular disc. In terms of sternoclavicular joint, the intra-articular disc, which we discussed, is fibrocartilaginous disc and is attached in a diagonal manner from the posterior superior clavicle to the manubrium sterni. Now, this is very important because the diagonal attachment helps restrain the medial translation of the clavicle. The absence of this attachment would cause the medial end of clavicle to override the sternum. Now the capsule and the ligaments, which we shall discuss in all the joints, these are non-contractile structures. That is, they will restrain the movement, they will not support the movement entirely like how the muscles perform the movement. So ligaments and capsules help perform the normal anatomical range of motion, restraining over movement or hypermobility. There are 6 degrees of freedom available, 3 rotatory degrees and 3 translatory degrees. We shall be discussing about that in the next lecture series. Let's discuss the ligaments here. We have anterior and posterior sternoclavicular ligament, we have costoclavicular ligament, and we have interclavicular ligament. The attachments are as follows. The anterior sternoclavicular ligament is attached anteriorly from the medial end of clavicle to the manubrium sterni and the first costal cartilage. Now, since it is attached anteriorly, it will limit the retraction, that is the posterior movements. So, when the shoulders go behind, retract, the anterior sternoclavicular ligament will stretch itself and will restrain the movement beyond anatomical limits. Okay. Now the posterior sternoclavicular ligament, since it is attached in the same manner but posteriorly from the medial end of clavicle to the manubrium sterni and first costal cartilage, it will restrain the protraction. That is when the shoulders come ahead, the posterior sternoclavicular ligament will stretch itself, only taking up the slack and will limit protraction and anterior glide of the clavicle. We have costoclavicular ligament, which is between the clavicle and the first rib or the costal cartilage attached here. It limits the elevation, superior glide, and clavicular rolling. So, when the clavicle lateral end depresses and the medial end goes up, that is this motion, from this motion to down, okay, depression. So while doing this, the lateral end goes into depression and the medial end of the clavicle goes into elevation. This elevation is limited by the costoclavicular ligament. It in turn also prevents the excessive depression of the lateral end. If there would have been excessive depression of the lateral end, it would cause compression of the brachial plexus and very major important vessels which pass through it. We shall discuss them in detail later. The interclavicular ligament attaches between the two clavicles, bridging the sternal notch. As we see here, the interclavicular ligament bridges the sternal notch. This limits depression and inferior glide. Again, when the clavicle elevates, it is going to prevent the depression of the lateral end and too much elevation of the medial end, serving the same purpose as we discussed now. Always remember for your CET that costoclavicular ligament limits the elevation and superior glide. And what is the reason and the benefits for the same? That is, it prevents compression of the brachial plexus and major important vessels passing via the space, that is axillary space. Now the acromioclavicular joint. It is a plain synovial joint which attaches the scapula to clavicle and allows transmission of forces from upper extremity to clavicle. So all the transmission of the forces from the upper extremity to the scapula, to the acromial surface of the scapula and via the joint formed by the acromial surface and the lateral end of clavicle, that is acromioclavicular joint, the forces now go to the sternum via the sternoclavicular joint. So from the appendicular skeleton to the scapula to the acromioclavicular joint to the sternoclavicular joint and now the axial skeleton. Now, core function, it is a plain synovial joint acting as a primary force transmission line. Please remember this for your CET and your Viva. The capsule itself is inherently weak and that is why it's reinforced by the ligaments. The vascular and neural spaces include suprascapular and thoracoacromial arteries, and the nerves supplying this joint include suprascapular nerve, lateral pectoral and axillary nerves. Joint motions provided here include upward and downward rotation, which is the primary movement. It also includes internal and external movements, which are the secondary movements, and also the anterior and posterior tipping of the scapula. This is anterior tipping, this is posterior tipping. We shall be discussing them in the next lecture series. The ligaments here, so actually we have two major ligaments here. The acromioclavicular joint capsule, which is one of the ligaments which actually holds the joint together. The capsule of this joint is very weak and it cannot maintain the integrity without help of the ligaments. These ligaments include the superior and inferior acromioclavicular ligament. So we have superior acromioclavicular ligament and inferior acromioclavicular ligament and the coracoacromial ligaments. So the superior and inferior acromioclavicular ligaments, they assist the capsule and they are reinforced by the aponeurotic fibers. So since they are attached here superiorly and inferiorly, they are reinforced by the fibers of the trapezius muscle up and the deltoid muscle over this area. So these ligaments are reinforced by the muscles and they in turn reinforce the capsule. Now the coracoclavicular ligament is made up of two portions, the conoid ligament and the trapezoid ligament. So the conoid ligament is conical in shape. It is attached medially, it is vertical and triangular in shape. So since it is attached medially and verticular, the fibers are straight. This checks the superiorly directed translatory forces. Now the trapezoid ligament, it is lateral and horizontal and is a quadrilateral in shape. That is why it is called as trapezoid ligament. And this checks posteriorly directed translatory forces on this joint. Moving on to the scapulothoracic articulation, this is not a structural joint, but it is situated between the acromioclavicular and the sternoclavicular joint behind on the thorax. That is, scapula rests on the thorax and it forms a functional joint in close chain with the acromioclavicular joint on one end and sternoclavicular joint on the other side. Now, the normal resting position of the scapula on the thorax is approximately 5 cm from the spine, that is 5 cm from the midline, and it spans usually from 2nd to 7th ribs. The positioning is as follows. It is placed into 35 to 45 degree internal rotation from the coronal plane, that is 35 degrees to 45 degrees internal rotation from the coronal plane as we see in this diagram. It is rotated internally 10 to 15 degrees from the vertical axis, that is anterior tipping 10 to 15 degrees from the vertical axis, and it is slightly upwardly rotated. As we see, the distance here is less as compared to distance here, that is it is upwardly rotated 10 to 15 degrees. Okay, this is upward rotation. This is upwardly rotated because this distance is less as compared to this distance. So now the resting position of scapula is clear to us. Let's understand the scapular plane, that is the position of the scapula this way in these dimensions is called as the plane of scaption, and this is defined by this 35 degrees to 45 degrees of internal rotation of scapula. Why this is important? Because testing in the scaption plane minimizes capsular stress, because when the scapula is positioned in this direction, the capsule and the joint space is little more lax, and that is why the movements and testing in this position is less painful and less stressful to the joint and capsular structures. Now, the essential support of the scapulothoracic kinematics is provided by the dynamic muscular forces, couples. Okay. So now we saw the upward and downward rotation movements which was provided by various joints which we discussed. So upward rotation is this way and downward rotation is this way of the scapula. Elevation and depression is up and down of the scapula, and protraction, retraction. So upward and downward rotation, for example, these are the scapula and this is the midline. Upward rotation and downward rotation. Okay, this is elevation and depression, and we have protraction and retraction. We'll discuss about them in detail in the arthrokinematic lecture series. Now always remember the upward rotation force couple, the trapezius muscle, upper trapezius this way, the lower trapezius this way, and serratus anterior. These are the vector direction of the muscles. These full upward rotation is mechanically impossible without the synchronized force couple provided by the trapezius and serratus anterior. Very, very important for your movements of the shoulder joint and your MCQs. Okay, so we'll discuss about them in detail later. Now moving on to one of the most frequently discussed joint, that is of the shoulder joint, that is glenohumeral joint. So glenohumeral joint is a ball and socket plain synovial joint which is formed by the articulation of the glenoid cavity, which is a concave cup-like shaped cavity with the head of the humerus which is concave. So it looks somewhat like this, the golf ball resting on a tee. Okay. Now glenohumeral joint is protected by the capsule, the ligaments which include transverse humeral ligaments, the coracohumeral ligaments, the joint capsule and the glenoid labrum. We shall discuss that. Before that, let's understand the placement of humerus and the head of humerus. So there are two important angles which you need to remember, the angle of inclination and the angle of retroversion. So the angle of inclination is formed by an axis which we can draw from the head and neck of the humerus and a longitudinal axis through the humerus. The angle formed by these is called as the angle of inclination, which measures around 130 degrees to 150 degrees. Next is angle of retroversion, which is formed by a line drawn through the condyles of the humerus and another line which crosses it through the head and neck of the humerus. The angle formed between these two arms is called as the angle of retroversion or angle of torsion, and it measures around 135 to 45 degrees. Now, what is the importance of these angles? So, since humerus is placed little into retroversion and this angle of inclination of the head and neck, both of this matches the scaption plane, that is internal rotation of scapula, which is 35 to 45 degrees. And the biomechanical insight behind this is that retroversion orients the head into glenoid fossa and helps prevent subluxation, dislocation, or any joint stress created by malalignment. Vascular supply include the glenohumeral joint relies heavily on the posterior circumflex humeral artery and suprascapular vessels for its blood supply. Now moving on to capsule and ligamentous details. So we have discussed that we have the fibrocapsular glenoid labrum, that is, this is a glenoid cavity and the labrum is attached at the rim of this cavity. We have capsule of the shoulder joint, which connects the shoulder scapula, that is glenoid fossa, to the humerus head. We have the coracohumeral ligaments, we have transverse humeral ligaments. Okay. Now let's move to capsule. So the important aspect and key feature which we need to remember is the capsule is very loose and redundant inferiorly. So this portion of the capsule, it is shown very big in the image, but actually the capsule spans till this area. So the axillary pouch, this is the axillary space, and the space occupied by the capsule of the shoulder joint here is called as the axillary pouch of the capsule. Since it is very lax inferiorly, the abduction moment of the shoulder joint like this will be allowed by the capsule by stretching. Okay, the capsule will take up the slack and just become tightened enough to let this upward motion of the abduction happen. Next, we move on to superior glenohumeral ligament. So, glenohumeral ligament has superior part, middle part, and inferior glenohumeral ligament complex. This inferior glenohumeral ligament complex is again made up of anterior, posterior, and inferior bands. Together, they are called as the ligamentous complex. Now, the superior glenohumeral ligament, it is attached here superiorly. So, since it is attached superiorly, it will limit inferior translation. Now, it is attached superiorly here, so it will not let the humerus translate inferiorly beyond the anatomical limit. We have the middle glenohumeral ligament. Since it is attached here, it will prevent the humerus anterior translation at 45 degrees of abduction. So, at 45 degrees of abduction, the anterior translation of humerus is prevented by the middle glenohumeral ligament. We have inferior glenohumeral ligament complex, which includes the three components as we discussed. The primary restraint against anterior dislocation at 90-degree abduction. So when we do abduction with lateral rotation at 90 degrees, the inferior glenohumeral ligament takes up the stretch and is maximally stretched, which prevents the anterior dislocation of the head of the humerus. This is also the close back position of shoulder joint. We shall be discussing about this in detail. So remember, the axillary pouch and the capsule is loose and redundant inferiorly, and surface area is 2 times greater than the humeral head. That is why we get maximum range of motion at the shoulder joint. Whereas the close back position, abduction and lateral rotation twist, that is abduction and lateral rotation twist the capsule on itself. The capsule gets twisted on itself, which eliminates the slack and mechanically locking the joint. A quick revision of the ligamentous sling mechanism, which we rightly discussed now. This protects the glenohumeral joint during abduction. So now we are actually discussing about the glenohumeral ligament series. So superior glenohumeral ligament, it is attached here superiorly. It will prevent the inferior translation of humerus at 0 degree, that is when arm is resting at the side in static position. Now, as we begin abduction, till 45 degrees of abduction, the middle glenohumeral ligament, which is attached here, limits the anterior translation. It will prevent the anterior translation of the head of humerus. Next is at the 90-degree abduction. That is, at 90-degree abduction, what we see is that the inferior glenohumeral ligament complex, the whole complex, limits the anterior and posterior shift via the hammock sling mechanism because it is tight at this position. This capsule twists on itself and prevents the anterior and posterior shift of the humerus head beyond the anatomical limits. Always remember, at 90-degree abduction, the inferior glenohumeral ligament is the primary static restraint against anterior dislocation. This is very, very important for your clinical reasonings, for your MCQs and your Viva questions. There is a quick brief review of glenohumeral and scapulothoracic joint. So these synchronize at a 2:1 ratio to achieve full elevation. For that is, for every 3 degrees of shoulder elevation, 2 degrees occur at the glenohumeral joint and 1 degree at the scapulothoracic joint. So there are various phases of setting phase, mid phase and the ending phase of the glenohumeral joint, and this is a basic understanding, that is 120 degrees of glenohumeral contribution to the abduction and 60 degrees of the scapulothoracic contribution. This causes a total of 180 degrees of shoulder abduction. We shall discuss this in the kinematics and kinetics part in detail later in the next lecture series. Now this is very important for your clinical perspective and clinical reasoning management. So this is called as the coracoacromial arch, which is formed by the coracoid process, the coracoacromial ligament, and this is the acromion process. This is called as the coracoacromial arch, which is a osteoligamentous vault which forms a roof for the head of the humerus. Okay. Now the structures included between the inside this space include various blood vessels, nerve vessels, and the bursae. These include bursa of subacromial and subdeltoid space, the rotator cuff tendons, the long head of biceps brachii, and the neurovascular supply. The contents are suprascapular nerve, rotator interval capsule. Rotator interval capsule is made up of the coracohumeral ligament, superior glenohumeral ligament, the superior part of the capsule. All these structures are located between the supraspinatus muscle tendon up and the subscapularis muscle tendon lower. We also have suprascapular artery, subscapular artery, axillary nerve, and suprascapular nerve. Now this is very important clinically because at the resting position, the space is of 10 millimeter. That is space between the acromion and the head of the humerus, which is spanned by this arrow, is 10 millimeter. With abduction motion, this space reduces to 5 millimeter during elevation within the rotator interval, that is within this space. Now why this is important? Because repeated overhead activities causes reduction in the space, and if this happens repeatedly with wrong biomechanical movements, then it can cause impingement of all these structures located in this space. So rotator cuff, always remember, the rotator cuff must forcefully depress the humeral head during elevation to maintain this 5 millimeter clearance and prevent mechanical impingement. What this actually means is why. So now this is your glenoid cavity. This is the head of humerus. According to concave-convex rule, when the humerus moves on the glenoid cavity, the roll and glide occur in the opposite direction. For example, this abduction motion, the roll is occurring superiorly, but the glide happens inferiorly. This inferior glide is provided by the rotator cuff muscles. If this inferior glide is not present, the 5 millimeter space will not be retained and instead will be causing impingement here upwards. We have discussed about this in our last previous lecture series of concave-convex rule also. So always remember the arthrokinematic movement, that is inferior glide, is very important. If this is not present, the 5 millimeter space that should have been there will be missing and will cause impingement of the humerus head on the acromion, and this is called as shoulder impingement syndrome. Again, our concave-convex rule helps us joint mobilization, and we have to strictly adhere to concave-convex rule arthrokinematics. Now we'll discuss the example of roll as we discussed previously. The convex humeral head moves on the stationary concave glenoid fossa. The roll and glide occur in the opposite direction. Therefore, for shoulder abduction, the superior roll and inferior glide is important. For external rotation, that is external rotation, posterior roll, the posterior roll of humerus and anterior glide is necessary. Without these, the capsule and various structures will get impinged. Rule of thumb, always remember, if elevation of the arm is restricted, posterior inferior capsular glides are indicated to restore normal arthrokinematics, because these glides are actually assisting the entire movement of the elevation. We have to perform them according to concave-convex rule to prevent any pain and assist in joint mobilization. Now this is a quick structured map made by me which will help you revise quickly. So extreme proximal stability perfectly translates into maximum distal mobility. When your shoulder joint or any proximal joint is stable, you can move your hand and distal joints easily. If there is no stability proximally, distal mobility is hampered. Remember, sternoclavicular joint, the role is axial anchor, that is sternoclavicular joint connects the axial skeleton to the appendicular skeleton. The AC joint, that is acromioclavicular joint, is the suspension strut which helps in force transmission from the limbs to the axial skeleton. Scapulothoracic joint is not a true joint, it is a functional joint which is gliding base for the scapula over the thorax. And glenohumeral joint is apex of mobility with a ball and socket structure allowing 180 degrees of abduction and flexion. Structure: SC joint is a synovial saddle plane with a fibrocartilaginous diagonally placed disc. AC joint is a synovial plane joint. Scapulothoracic joint is a functional muscular interface because it is not a true joint. It is connected to the thorax via various muscles. We will be discussing later. And GH joint, that is glenohumeral joint, is a synovial ball and socket joint. Primary restraint of the sternoclavicular joint is costoclavicular ligament. Please remember all of these. The AC joint is the coracoacromial ligament. The scapulothoracic joint includes thoracic congruency, how the thorax is placed, because it all depends on the position of the spine and the scapula, and the force couples made by the muscles. And the GH joint, which includes the dynamic capsule and inferior glenohumeral ligament complex link. This is the close back position which restrains the anterior and posterior translation of head of humerus via the IGHLC. Always remember, maximum hand mobility is only mechanically possible because extreme proximal stability translates perfectly outward through a highly articulated kinematic chain. Now I'll request you to just screenshot this slide because this is going to help you in your CET theory and revision. Scapulohumeral rhythm is of the ratio 2:1, that is 120 degrees of glenohumeral movement to 60 degrees of scapulothoracic movement. The scapulohumeral clearance 10 mm is the resting position, which drops to 5 mm when overhead movements are performed, and this should be retained by the rotator cuff tendons. The scapulothoracic joint upward rotation force couple is provided by the upper trapezius, lower trapezius and serratus anterior force couple mechanism. Primary anterior restraint at 90-degree abduction is inferior glenohumeral ligament joint complex. AC joint ligaments include two portions, that is conoid part and the trapezoid part. Conoid is vertical and prevents the superior forces versus trapezoid, which is horizontal and prevents posterior forces. Okay. Now, so your shoulder basics are very clear. If you understand this properly, the kinematics becomes much more easier, which we will be discussing in the next part. In the part 2, I'll explain scapulohumeral rhythm and arthrokinematics, the most confusing yet the most asked topic in exams and very important for your clinical practice. If you are preparing for BPT, MUHS or CET, make sure you subscribe. This series will cover entire shoulder in the most exam oriented and clinical way. And also, if you want structured, prepared notes and guidance for physiotherapy exams, I have started a mentorship program. Details are in the description. You can check it out. Thank you.